So in people with diabetes, they have a doubling of the risk of cardiovascular disease. And even though the mortality rates have actually come down in cardiovascular events, with existing therapies, they still have a higher risk. So we know that statins work, high doses are better than standard doses, and ezetimibe lowers that further. But often in these patients, they have this so-called atherogenic dyslipidemia. So in addition, their LDL cholesterols are not particularly high. They have other abnormalities, particularly in triglyceride-rich lipoproteins, and low levels of protection from low levels of HDL. So as a result, they have a high absolute risk, and these individuals may benefit from further add-on therapy, particularly with reducing atherogenic lipoproteins. So that's the biggest challenge, and you can only go so far with statins and ezetimibe. So there are two Odyssey studies in diabetes. In the previous Odyssey program, in about 4,800 people in the phase 3 studies, there were about 30% of people with diabetes, but the studies had not included people specifically for having diabetes. In particular, we'd not really focused on people treated with insulin, and that's important because you've got two biological agents if you're adding a monoclonal antibody and insulin. So there are two studies. One is the diabetes insulin study, and these are people, both type 1 and type 2, to see if they gain from the same amount of LDL reduction with alirocumab, a PCSK9 inhibitor, and also to look at whether that impacts on glucose control in people with diabetes. And the second one is the Odyssey diabetes dyslipidemia study, and these are people with higher triglyceride levels, because one major question that we get asked is, after statins, what do I do? You know, is fenofibrate an option? Should I be adding fish oils, niacin? And so what we compared was alirocumab against standard care and focused on an important endpoint, which is non-HDL. And that's the first time we looked at non-HDL as a primary endpoint, not LDL cholesterol, because it's a better marker of risk, residual risk in people with diabetes. We showed last year in this sort of pooled analysis of 4,800 people that if you look at the entire population studied in Odyssey, so these were people with ASCVD or high-risk features whose LDLs were high despite maximum tolerated statin, or they were just intolerant, you basically could reduce LDL cholesterols down to about 25 mg per deciliter. And you saw a continuous relationship, so no lower threshold for below which you didn't get any additional benefit. So there is no lower threshold. Lower is clearly better and lowest is best. We showed that last year, and we showed that also for ApoB and non-HDL. And if you looked at percentage reductions, the greater the percentage reduction with these therapies, the better the benefit. And that's been supported by the recent Fourier study as well, which showed that in a large patient population, you reduce clinical events by between 15 to 18%. And a recent publication showing again the same thing that we'd shown last year in Circulation, that there's a continuous relationship between LDL and risk, and the lower your LDL, the better, but it's also safe. That's the other key thing. In terms of populations with diabetes, we have now started to show that this is a group that probably should have more than just a statin. The Improve It trial was the first one that showed that add-on therapy gave you much bigger benefits in populations with diabetes. They gained more than 5% absolute benefit compared to 2% in the overall population. So that was actually quite important. And more recently, we've seen that with the lipid-lowering agents like the monoclonals, you get a similar percentage reduction, but because their absolute risk is that much higher, the benefit should be greater. Now, in a couple of days' time, we'll see the presentation of the Fourier diabetes analysis, which should give us some insights about the benefit of that treatment in that patient population. And we'll see also if in people with ASCVD and diabetes, you gain a bigger absolute benefit. And next year we'll be obviously hoping to release the results of the Odyssey outcome study, which has 1/3 of the patients with diabetes and ACS. So that's the highest risk group of all. So we'll really be able to see whether that gives you even bigger benefits. So it's an exciting time for us.